systematic. It's just that I'm an addict for your love. Nothing wanna hold you. Never ever should have told you you're my only girl. Nothing wanna hold you. Never ever should have told you you're my only world.
Georgia, Georgia, pudding pie. Kiss the girls and make them cry. Georgia, Georgia, pudding pie. Kiss the girls and make them cry. Georgia, Georgia, pudding pie. Kiss the girls and make them cry. Georgia, Georgia, pudding pie. Kiss the girls and make them cry. Georgia, Georgia, pudding pie. Kiss the girls and make them cry. Kiss the girls and make them cry. Kiss the girls and make them cry. Georgia, Georgia, pudding pie. Kiss the girls and make them cry. Kiss the girls and make them cry. Kiss the girls and make them high. Georgia, yeah. Georgia, yeah. Kiss the girls and make them cry. Kiss the girls and make them cry. Georgia, yeah. Georgia, kiss the girls and make them cry. Kiss the girls and make them cry.
Hello girl, it's been a while. Guess you'll be glad to know that I've learned how to laugh and smile. Getting over you was slow. They say old lovers can be good friends, but I never thought I'd really see you. I'd really see you again. I go crazy when I look in your eyes. I still go crazy. No, my heart just can't hide that old feeling inside, way deep down inside. Oh, baby, you know when I look in your eyes, I go crazy. You say he satisfies your mind, tells you all of his dreams. I know how much that means to you. I realize that I was blind just when I thought I was over you. I see your face and it just ain't true. No, it just ain't true. I go crazy when I look in your eyes. I still go crazy. That old flame comes alive. It starts burning inside, way deep down inside. Oh, baby, you know when I look in your eyes, I go crazy.
Hello. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us today for the webcast entitled Thinking Long-Term, Data-Driven Decisions About PrEP. Today's program is supported by an educational grant from Gilead Sciences. I'm Dr. David Wohl. I'm a professor of medicine and site leader of the Global HIV Prevention and Treatment Research Site. I'm also co-director of our viral hemorrhagic fever clinical research group here at the Institute of Global Health and Infectious Diseases at the University of North Carolina, Chapel Hill. Today, hopefully, Margot Savoy, Dr. Margot Savoy will join me. She's helped create this content and oftentimes is able to help, and you'll hear more from her later on. Margot, I don't know if you're on. Not yet. No worries. So in our first module, we did discuss an open conversation about sexual history taken in a non-judgmental way, and Dr. Savoy led that expertly. Today, we'd like to take the next step and apply clinical trial outcomes to the decision-making regarding HIV prevention and consider in particular long-term impact on bone health, lipids, and renal dysfunction. So if you recall, when we last saw our patient Dylan, he had come in for his annual checkup and he asked about whether Dr. Savoy thought PrEP would be a good idea for him. In the patient simulation that caught Dr. Savoy, who I think was definitely a nominee for an acting award, definitely caught her a little bit off guard, but it was good jumping off point for us today as we think about what considerations we should be thinking about when initiating PrEP. So let's start with some of the basics. And here is CDC guidance regarding who should be prescribed PrEP. And these have been tweaked a little bit over time, and I think are a little bit more user-friendly. But basically, we're talking about sexually active people and people who inject drugs. And in each of these situations, there has to be some element of risk of transmission of the virus from one person to another through the biological mechanisms by which that occurs. And you could read this for yourself, but for sexually active people, certainly that there is some exposure to someone who could be potentially HIV positive. And in people who inject drugs, we're really talking about people who share injection equipment with others who could be infected. So we have two different agents that we use for PrEP here in the United States, TDF FTC and TAF FTC. So a real question that comes up quite a bit is what are the factors that should be considered when deciding which of these formulations to choose? Because they're similar, but there are some distinct differences, especially for adolescents and young people. So consideration number one is the type of person, the type of activity that they have. So in our limited time, let's consider just sexual activity and why that is really important. Next slide. Great. So there's a number of different things that we could think about when we think about assessing the risks through sexual exposure, including the types of behaviors that a person engages in that may expose them. And we'll talk a lot about this because I think for TAF and for TDF, along with FTC, both have been found in clinical trials, as we'll talk about, to be really efficacious and safe. But there are some differences, and we should hone in on those. So one of the things that we think about is type of sexual activity, and also who the host is, who the patient is. So type of sexual activity could be important because we know that there's different penetration of the different active agents into different tissues of the body, and that this can vary by who the patient is. So in particular, we know that for receptive vaginal sex as opposed to receptive anal intercourse, there could be different levels of the active agents, the active metabolite of the agents that we're looking at to prevent HIV infection, such that we don't have as much data on TAF and TAF's ability to deliver tenofovir into the vaginal tissue and the cervical tissue to the extent that we have for TDF. And we also know that rectal tissue seems to be really an area where we can see high concentrations of drug to protect against HIV. Thus, you'll see that TAF FTC for cis women is not something that is recommended at this time. So when you look at the package insert and the recommendations for TAF-FTC, it's for people who can get infected other than through vaginal sex. So there's other things that we have to think about that differentiate TDF from TAF. And next slide hones in on one of these, and that's renal health. And I think there's two areas that we're going to focus on today that may be important for differentiating between TAF and TDF, and that's bone and renal. So for renal health, especially for younger people, we don't have to worry as much, right? Because younger people tend not to have as many issues as far as kidney function. Certainly in older individuals, this is something we worry about with the confluence of diabetes or hypertension and other things. But that's not to say that there aren't some who we might prescribe this to who are younger, who may have reduced renal function for one reason or another. And so before prescribing TAF, I think it's really, or TDF, it's really important to understand where people are at as far as their eGFR or E-creatinine clearance, their estimated creatinine clearance. And TDF, as we know, should not be prescribed to anyone with an estimated creatinine clearance or GFR that's less than 60 mils per minute. We also do monitor creatinine, especially in people on TDF over time, if possible, at least, every 6 months, possibly every 3 months for those who might have risk factors for renal insufficiency. So what kind of data do we have that can help us understand more about renal health in people who are on PrEP? There's a few different data points that we could look at. One's a real world study of over 4,500 participants who did get TDF-FTC. And to look at, over time, rates of renal impairment and over 2 years of cumulative risk, renal impairment was 1.7%. So pretty low. I mean, really 98% of people did not have any evidence of any sort of renal impairment or renal damage. And significantly higher risk was associated with older individuals and those with pre-existing renal dysfunction, as we'd expect. We'll talk more about the Discover trial. Discover trial is really important because it compared head-to-head TAF-FTC and TDF-FTC over time in cisgender men and trans women. And this study has followed people even out past 96 weeks. And TAF-FTC people on that arm experienced increases, so better glomerular filtration rate, and declines in markers of renal insufficiency or glomerular dysfunction with protein wasting. So biomarkers of renal health were better in people who are on TAF-FTC compared to those who were assigned TDF-FTC for PrEP. So these key differences favor TAF, especially when we're talking about renal proximal tubule function, and especially in people who might be older. And in just as far as efficacy, TAF-FTC was non-inferior to TDF-FTC. So worked just as well, if not better. What about bone health? So lots of different risk factors for bone demineralization, some of which do exist in younger people. So we do see smoking, we see poor diet, alcohol disorders, methamphetamines, sedentary lifestyle, even eating disorders, vitamin D deficiency, low BMI. So there have been studies in young people that definitely do demonstrate that BMD could be low, even in people in their early 20s and later 20s. We also know that adolescents and young people less than 25 years of age are still developing bone mass. And so this is a critical time point for many of these people and their bone health. And again, that's why there are and have been for quite some time, especially among pediatricians and adolescent medicine doctors, concerns regarding TDF in this population. Next slide. So again, looking at the Discover trial data where DEXA scans were done to look at bone mineral density in the patients who were enrolled in the study, or the clients that were enrolled in the study, you could see here that when we look at TDF and TAF and look at the spine and the hip and the changes over to the 96-week period that was observed, you can see in blue, the darker blue, that's an increase of greater than 3% or 3% or greater increase in BMD, whereas in green, we see a 3% or more decrease in bone mineral density. And the lion's share of the decrease in bone density occurred in those who were assigned TDF. And it was much rarer to see that in those who were assigned the TAF. And in fact, people on TAF tend to gain bone mineral density over time, which is really interesting as well. And that would make sense because this was a fairly young population. Next slide. Another consideration beyond just the bone and renal issues that we've talked about is adherence. And adherence and persistence of PrEP is a huge issue, especially for younger people. And there have been a number of different studies that show that as far as PrEP, as well as for HIV therapy, that younger people tend not to adhere as well as older individuals. And so really understanding more about how we can keep people adherent and persistent on their PrEP is important, because PrEP, when taken as it should be, is close to 99% efficacious. It really does work. So in general, what we can do to help support younger people is really maybe reduce the barriers to their adherence and persistence. So that there's a list here that I think you can consider, including dealing with mental health issues, including substance use disorders, really trying to address any side effects early before they lead to interruption and persistence, and then possibly exposure. And then, just overall poor health status and poor health literacy, I think, could be addressed, especially to both primary care. Perceived low risk of infection is another major factor. And we see this oftentimes when people feel like, well, I don't feel like I'm at that much risk, when they actually are. And so just trying to check in with them, give them a little bit of a reality check that, well, don't you think that it could be possible, given your exposure history, given your sexual behavior, given whatever you're doing, that there could be somebody who you could interact with who might be HIV infected, and really help people, kind of help lead them to understand that their risk may be higher than their perception. We also have to try to figure out ways, just like we do for any medication, to make things easier for people, right? To make it more convenient. And we'll talk about that in a second. And then deal with some really complicated issues, which may be some stigmatization. People may feel, not always, but people may feel like, well, maybe maybe this is a sign that that I'm doing something I shouldn't be doing, or people will judge me for taking PrEP. And there's a whole bunch of structural and sort of societal issues that are wrapped around that are complex, and that we have to start addressing if we're going to understand our patients better to help support their adherence. Next slide.
Dr. Wall, one of the things that I also think really is very helpful in thinking about teenagers in specific is that sometimes they just forget. And so helping them figure out ways to have a reminder system, because remember, they're feeling well when they're taking the medication, and they don't necessarily perceive themselves as having sex every day necessarily, right? So they may not even think that they're putting themselves at risk that day, and helping them to figure out how they might be able to remind themselves, even on the days when they're not necessarily being active, that they still need to be taking the medication, is something beneficial and worth talking about as a group.
It's actually really important, because the one thing that we really want to avoid is somebody stopping their PrEP, continuing on some level of risk activity, getting infected, and then starting back on PrEP. Because when you do that, you could really cultivate drug resistance. And so that's why we really have to follow people closely, and also warn them about that beforehand, not be reactive, but be proactive, and warn people that could happen. And the way that we avoid that is staying on PrEP, or being completely abstinent from the activity that could lead you to become infected. And so I think that's really important to educate folks about. There's a number, and this is really important because Dr. Savoy brings up a really good issue of like reminders and just forgetting. Any of us who have teenagers know that, forgetting is a big part of why things don't get done. I don't remember, I forgot to turn it in. That's pretty common. For the evolving, executive function that a lot of these younger people have. So this is a really good way to think about this. And I like this, social ecological model, if you will, of the onion skin, of the individual level, the provider level, and the societal level. And here you can see the first thing is external reminders. Now that people have cell phones or Apple Watches or whatever it is, a reminder just to take your medicine, to take your PrEP. That could be really useful. Pill boxes, you either love them or you hate them. Many people like them and they could carry it around with them. Tying it to some activity that you do every day. Hopefully you brush your teeth at least once every day. And again, working on that perceived risk of infection, being honest with people, saying, that doesn't sound like you don't think that that's too risky, but I'll tell you, there is this risk, and let's talk about that and help you, if not quantify it, at least qualitatively understand there is a risk of getting infected and why PrEP may be a good idea. And that feeds into its benefits. And then you can see for yourself, there's provider support, and I think establishing a good rapport, as we talked about last time, and avoiding some of the pitfalls that come with, limited time to talk to people in the clinic, some of the barriers we faced during the pandemic, and really trying to focus in and really listen, I think, to our patients would be really helpful too. More complicated can be societal support, right? Because of judgment and because of stigmatization. But if there can be family or peer or partner support, that could be fantastic. And again, this may be where they serve to help remind the client that, did you take your medicine? And I think many of us could benefit from that. And then reducing financial barriers is key. People have to pay, they're much less likely to be able to adhere and be persistent with their PrEP. Next slide. I'm not seeing the next slide move, but we can talk about it anyhow. So there's this idea of maybe some SMART goals. And Dr. Savoy, I want to ask you to tell us a little bit about, maybe SMART goals that we can use when we think about this for PrEP.
Absolutely. So for those of you who were here with us the last time, you know that we like to summarize our discussion, but just sort of thinking about what are things that we can take away from the program that we might be able to put in practice tomorrow or next week when we're in the office. And so some really good SMART goals for this particular session are things like emphasizing to our patients that PrEP is highly effective against HIV and that it can be important, particularly if you're going to be taking it daily, that you can't be sort of taking it and not taking it. So how might you be able to pull that into your daily practice and help educate our patients? Factoring in that there's risk factors for long-term negative impact on bone and renal health. So keeping in mind that as you're picking which treatment choice for patients, it's not just about what it costs or maybe what their access is to a particular medicine, but maybe it actually has more to do with their own health and what their risk factors happen to be. So if they have bone or renal disease, and you might need to choose one medication over the other. Counseling patients about adherence on each of their follow-up visits and sharing strategies about how they can implement into their daily lives ways to promote their adherence, remembering the things like using your team to help support you or picking daily activities, things that you're doing every day, like brushing your teeth, which might be a reminder. So how might you implement adding that counseling into the work that you're doing with your patients every day? And then finally, maybe recognizing that there are some social determinants of health that could impact their adherence, and any work that you might be able to do to help minimize those or help your patients to minimize those might be of a benefit too. And so giving some thought to those and seeing whether there's stuff that you could do as a goal, whether you could pick something that's specific, something that you can measure, something that you could actually attain that would be relevant to the practice that you're taking care of, but that you could get on a time limited thing so you could get it started sooner rather than later.
Wonderful. That's great. So this is when we can take some question and answer. So please type in your question and submit them so that we can address them. So we have about 10 more minutes and already we have 10 questions. So we'll try to get through them. First question, as we just talked about, how do we reduce barriers, especially financial barriers for getting our patients PrEP? And Dr. Savoy, I mean, certainly for me, this has come up quite a bit. Good news is I think the vast majority of people can get PrEP for free. And that means the medicine itself. And either they can get it through their insurance or they may qualify for manufacturer's assistance program or get a copay card that pays the copay that they may have due to their insurance. Now, it doesn't work 100% of the time. There are some people who fall through that net. But by and large, I've had really great success getting PrEP paid for. Is that your experience as well?
It has been. One of the things I think that's critically important, though, is to remember to ask. So sometimes I think we make assumptions that folks automatically have a way to pay for it or that they've thought about what the cost may be. And maybe it's not as simple as them just taking their medicine prescription to the pharmacy and picking it up. You may have to do a little bit of legwork, getting them connected to some other programming. But if you don't ask the question, you may not know that they're having financial trouble or that maybe the prescription plan that was working before isn't working anymore and that they may need help so that they don't fall into that group of people who sort of starts and stops depending on how much income they have on that particular month. And so honestly, I think one of the easiest things that you might implement, even just as a SMART goal, is learning to ask people whether or not they think it's going to be a problem or telling them how they're going to reach back to you if they do run into trouble.
Absolutely. And I will say one more thing about finances is while the medication is covered, some of the testing, and this has come up in some of the questions, and Dr. Savoy and I could talk a little bit about what are the real, absolute tests that have to be done as part of PrEP. And I think it's a very short list. It's not a long list, but I think the one thing that we all recognize is that you have to have really good understanding of whether or not the person's HIV infected before you start PrEP, because it's minimalist therapy. If we're starting PrEP and we're treating HIV, it's not sufficient, and resistance could be cultivated pretty readily. So we want to know if someone's HIV infected. So, a good HIV test is absolutely necessary. So what other things do we need? We really do also want to understand whether or not someone's hepatitis B infected, because TAF and TDF both are very active against hepatitis B as well as HIV. So I think understanding whether or not someone's hepatitis B infected is important, because if someone is chronically hepatitis B infected and you treat them with one of these drugs, discontinuing it when the person no longer is at risk could lead to a recrudescence of their hepatitis B. We talked about creatinine, and that doesn't mean a Chem 28. It just means a creatinine. You don't need a whole lot of other testing at all. That could be much more affordable. And then we really do STI testing, at baseline and regularly, because folks generally are at risk for other STIs. But there really isn't a necessity to do a whole lot of testing here. But those tests could add up and people could get a bill for those. And that has been an issue for some of my patients, Dr. Savoy.
Yeah, and I think sometimes it has to come back to our ability to figure out what the coding is. So sometimes, for example, if you know the person has other medical conditions, so you're going to be testing, for example, for the creatinine because you also have diabetes or some other medical problem, being thoughtful about how you're choosing the codes helps sometimes too.
Yes. Absolutely. And being creative. Sometimes we send some of our folks, maybe not, 16 or 17-year-old, unless, you can. We might say, well, some of the testing that we're doing, such as STI testing, could be done at the health department for free rather than our clinic or our hospital. So getting a little creative about some of this, I think, has also been very helpful, but really recognizing there are other costs associated with PrEP besides the medication. What about drug-drug interactions? The good news is there really aren't major drug-drug interactions with drugs that we have here in the United States that we use commonly. So for TDF or for TAF, so not too worried about it. For both of these drugs, the issue is not so much that even TDF hurts the kidneys. It's just that at high levels, TDF could hurt the kidneys. So other things that inhibit kidney function or that potentiate that nephrotoxicity potential. So people who are on non-steroidals, heavy doses, things like that, that's where we get concerned. It's not so much a drug interaction, but sort of a synergistic effect of renal toxicity. But really, there's very little that you have to worry about as far as drug-drug interactions for TDF or for TAF.
This is one, though, that I do like to remind folks to let people know if they're, for example, presenting to an emergency room or an urgent care. One place where sometimes people get into trouble is when you have multiple drugs that are, for example, coming after your kidney at the same time. So thinking about like the urinary tract infection where you're going to be putting them on, say, Bactrim, and they may have an interaction with the medication, not because it actually is an interaction between the two medications, but both of them could cause trouble for your kidney, similar to the NSAIDs. And so I do try to remind people that, I'm not saying that you can't take the medicine and it's not that that's going to necessarily cause you an issue, but you want to let the doctor know that you're taking it, and don't try to hide this one because it could cause you trouble if we started you on something not realizing you were taking two.
Right. So nephrotoxic drugs piling on top of the TDF. Again, another advantage of TAF, and I will say that many providers who do use TAF FTC for PrEP really are pretty lax about even following creatinine because the risk of anything happening in the kidney with TAF is fairly low. Another question, let's go for it. What are some of the side effects I should be looking out for with either of these formulations, and are they transient? The number one side effect that we've seen from PrEP, especially TDF, but also TAF, could be GI. And so nausea is not very uncommon. We can see it in double-digit %, certainly not the majority of people. It's usually pretty transient, such that we just see it for a week or so and pretty mild. But there are some folks who will complain about this. It's another reason why I like to see people about a month after I start PrEP and certainly have open lines of communication before then. so that they can tell me if there's a problem before they just stop the medicine on their own. Other than that, again, other than what we talked about, which is sort of the potential longer term things, especially to be honest with TDF, where we could see over time slight, a rare but certainly significant risk of renal impairment of some degree and its effects on bone mineral density. But overall, these are really well tolerated medicines. Dr. Savoy, anything to add as far as thinking about side effects that you've seen?
No, I agree. Like what you named are the ones that I've heard most commonly mentioned as well.
Another one that comes up is how often should we screen for HIV? And I'll add on STIs. What's your strategy? And has that changed over time when you have folks on PrEP?
For me, I typically have them do it quarterly because I have them come in quarterly to check, and anytime they think there's a risk. So we talk about in the beginning that if you think you had an exposure or something that you're concerned about, you obviously can come in a lot sooner if there's an issue, but that we should probably stay on a pretty quarterly basis, like just sort of checking in and making sure that you're still doing well.
I like that. So same here. So like I said, I like to touch base with people about a month after we start, make sure we're on the right track, maybe just give them a month's supply, a month without a refill. Then after that could be every 3 to 4 months where we have them come in, we do an HIV test. I like the 4th generation test, the antigen antibody test. The window period around that, for having a false negative is pretty narrow, about a week or so. So I take a good sexual history, find out what's been going on, if there's any symptoms associated with acute HIV, and then just, do STI testing as is appropriate for what their activity has been. And then see them again another quarter and give them enough of a supply to last until then. So I think that's a very practical approach for doing that. Let's see. A lot of this has to do with how do we communicate with people and introduce things. I'm going to answer the question directed to me about the Discover trial. So Discover, if you remember, that was the TAF FTC versus TDF FTC trial. Head-to-head study, large number of people. And, the absolute numbers, so good news is, over 5,000 people, very few infections overall. Good news is, and even fewer infections that occurred during the study. Some of the infections were those that existed just at the time of screening and that were missed by the time baseline came around, we were able to discover them. But so good news is very few incident infections, and even by absolute numbers, lower in TAF versus TDF. But when you look at the non-inferiority margin, non-inferiority was achieved, which is really great. So couple that TAF works just as well, if not better than TDF, but just as well as TDF, and had a better bone and renal profile. I think that makes me feel really comfortable in using it in the population that was studied in Discover, which again was cis men and trans women. Again, we'll get more data on cis women and whether or not TAF provides the same sort of benefits. Biologically, it should, but I think we want to see a little bit more clinical trial data to support that. And anything to add there, Dr. Spoy?
Nope, I agree.
Awesome. Well, these have been some great questions, and there's others about really tough issues that I think we addressed a little bit last time, which is talking a little bit about, how do you introduce a complicated and touchy topic, especially to adolescents? And I think that's important to do. And again, I'd refer back to our last discussion where I think we spent a good amount of time trying to help people understand maybe some of the sensitivities and approaches. And I think Dr. Savoy's video was really instructive as well. So thank you for joining us today. If any of your colleagues missed our program, we have 2 more opportunities for live Q&A. That's Thursday, July 22nd at noon Eastern, and July 30th, that's a Friday, also at noon Eastern time. So please share the link with team members and colleagues. And meanwhile, stay safe, and thank you again for providing great care, including preventive care, to your patients and clients.
I was captivated, and I waited for you, babe. Every lonely night, so fascinating, hesitated just a bit too long. You got me wondering if I'll be missing you. Will he be kissing you? I guess we're gonna have to wait and see who will be the fool tonight.